Let's switch gears a little bit now and talk a little bit about cost. Obviously, as Neal mentioned, that we've got a number of therapeutics that all carry a fairly steep price tag. David, from your experience, how should urologists approach looking at this in terms of balancing costs, but at the same time preserving access to high-quality care, taking into account this steady stream of new technologies that's coming down the pike for us and screening tools, those types of things?
That's really a good question and a difficult one to answer. There's a number of different tacks you can take. I dropped back to 20 years ago when we did this little study with an anti-androgen called flutamide that showed that you could improve survival rate by 4 to 6 months in people with advanced disease. And that was met with urologists by, well, this is going to cost a couple $100 a month, and is that 4 to 6 months worth it? And that argument prevailed for a long period of time. And now we're into thousands of dollars a month in differences. My philosophy is, things tend to take care of themselves and let the system go forward. I mean, our goal is to provide the best care we can for patients, and we have to look at what's out there. We have to be cost conscious, but I think we also have to let somebody else is going to figure this out to a degree. And so my philosophy has been to offer the patients the best thing we can, and some of these treatments cost a lot of money. If we look at, for instance, somebody mentioned Provenge already. You mentioned that you were doing infusions. It's an expensive treatment to put together. It's not just an inexpensive thing to do. So we understand that. I think it's going to get even more interesting because what I see happening is that there is going to be a shift in care for advanced disease to more urologists now, particularly with the oral drugs and some of the other drugs that we can give. And the next big step, in every cancer that we prolong life or cure, it's not just one drug. You mentioned Larry Einhorn. We played around with cisplatin in the Southwest Oncology Group with monotherapy for years, got responses, but it was only when you put other drugs with it. And I think the same thing applies right here. It's not going to just be one drug, but it's going to be 2 or 3, and not just sequencing one after another. It's going to make a difference. And that's going to be a very expensive ordeal, and we're going to have to figure out how to deal with it.
So Mark, give us your thoughts in terms of cost as you get ready to step into the becoming president of AACU and obviously have a fair number of not only small and large community practitioners that will be sort of under your umbrella.
Well, I think cost is a big issue. I think Dave alluded to it some, that it does take care of itself in some ways. I mean, the cost of many of our therapies are quite expensive in the beginning. And then as they're larger productions and more people using them, and then they find ways to pay for them, the cost kind of evens itself out, and they find a role in urology and in medicine. I mean, it's not unique to urology, it's not unique to the United States, it's a world problem too. I mean, when you talk about vaccines for malaria or for HIV treatment in sub-Saharan Africa, I mean, this is a big problem, and it's going to continue to be a big problem as we get better with our medications and our devices and our genetics and our stem cell therapies. I mean, those things, the cost is going to be a big issue. And I don't have an answer to it, but I do think that it has to enter into our discussion when we talk about innovative therapy.
My take on this is I'm very concerned right now, especially for urologic oncology. You know, we've had this incredible breakthrough in FDA-approved therapeutics in advanced prostate cancer. And right now, of course, there's expense associated with new therapeutics. There's a lot of expense associated with research and development. And somewhat uniquely about the United States is that's where all the countries, after they get, or the companies, or whether it's a biopharmaceutical or a biotechnology company, they come to us because we're a country that's wealthy enough to pay for many of these things. And so there's sort of a perverse perfect storm that if we are economically constrained, where will this R&D go on? And how will we, as urologists, the purveyors of care for our patients, we have to make sure they get these therapies. So where there's this tension going on right now with ACO models and the Affordable Care Act to say we've got to harness back payment for a lot of these therapeutics. We all are very familiar with the United Kingdom and the NICE program, which isn't very nice. They don't pay for EMA or FDA-approved therapeutics in advanced prostate cancer. And so I think the urologic specialties and the associations of AACU, LUGPA, AUA, SUO, it's our burden, our responsibility to make sure that our patients can get access to these therapies, albeit, as you said, David, they're expensive. But that's the price we pay for research and development. And we have this unique opportunity to really make cancer, prostate cancer, a chronic disease, unlike some other cancers. And yet, the irony is there are a lot of people saying, well, we don't want to pay for that now. I'm very concerned in these ACO, which is sort of a euphemism for a capitated managed care plan, that we may not be able to afford some of these therapies for our patients. I don't know if you feel similarly.
I can remember not too long ago that these compounds called LHRH agonists came along. And there was just a huge backlash about, well, we're not going to pay for this when you can have orchiectomy. And there are actually healthcare providers, third-party payers, that said, we'll pay for 2 or 3 months, and then you get an orchiectomy or you pay a huge copay. And that turned around. And I think we've got to let I'm a believer in the American system of competition and letting things alone, that you do the right thing and things will settle down. Now we're going to have people looking over us, but we need to fight for the patient and what's right. And I think that, as you mentioned, we've had 5 new drugs approved in the last 2 years. We've got 5 more coming, and they're all, a lot of them are different. They're exciting, and I think we've got to figure out how to put those together. It wasn't so long ago, in prostate cancer, in the time I was in the Southwest Oncology Group, Mark was there with me. We studied every drug known to mankind in advanced castrate-resistant, then called androgen-independent prostate cancer, and nothing worked. And along came this little lead with Taxotere. Wasn't a huge step forward. But then everybody started building on that. It made people think. They start looking at other mechanisms of action. We got away from just one thing. And so I think we should be excited, not depressed about whether we've got a lot of costs and things like that. Let's try to work with it.